One of my favorite areas, and where I think there is a lot of opportunity and potential to really advance the field, is around health equity and adaptation models and implementation science. So this area has really grown. So disparities, when we're talking about disparities, we're thinking about health differences and inequities that are closely linked often with different types of social or economic disadvantages. I think in implementation science, we've had a huge focus on understanding and addressing racial and ethnic health disparities, but I think it's important to recognize that there's multiple social dimensions in which we could be understanding these issues. And here are just a few to mention. But I think it's critical to recognize that we've tended to think about understanding and addressing racial and ethnic health disparities, but there's, again, potential to do a lot more work by other social dimensions, and also thinking about, again, issues of kind of intersectionality, and really being really specific about the groups and settings in which we're working. There's also been a shift in the field. I was at an implementation science cancer consortium recently and got to lead some of the work around health equity and context and implementation science. And I think, across public health, there's been increasingly recognition of the critical role that social determinants of health play in shaping health and health disparities. And importantly, a move towards not only thinking about disparities, but actually promoting health equity and thinking about what are the conditions and opportunities in which people can be healthy. And I think in implementation science, I think, again, a lot of the work has been more focused on tracking the disparities and less about the actionable opportunities to actually think about implementation from an equity lens. So I think there's huge opportunities in this area to be really much more explicit about how we could advance the field in this area. When we think about our interventions, one of the issues is that all of our interventions have not necessarily been tested and are not necessarily equitable in terms of actually improving health. There are some, within our databases, some really good examples of specific interventions that have been found to be effective for specific either racial and ethnic groups or lower income population. So I'll just highlight a few because I think it's important to recognize that there is an evidence base for some of these health issues. So, the CATCH trial is one for physical activity, VERB, Take 10. So we have some good examples specifically around physical activity and youth related interventions to promote physical activity. So we have some evidence base there. For nutrition, we've seen a lot of school-based programs, so things like Planet Health. We've also seen community and church-based programs, so things like 5 a Day for Better Health and Body and Soul. Body and Soul has been one of the most widely disseminated and implemented programs nationally. It's been highly, highly successful. It was originally focused on African Americans and nutrition in churches. It's now been adapted for multiple populations. There's lots of work going on in community settings and at the local level in building an evidence base for this program. So that's really been a success story. And then there's lots of other examples of kind of thinking about the food or social environment being addressed in terms of ways to think about community gardens or farmers markets and availability of fruits and vegetables. And again, increasingly we're finding an evidence-based, specifically focused on thinking about its impact on more diverse populations. With cancer screening, we also have a pretty strong evidence base, particularly in community settings for things like, peer-led, community health worker, and lay health advisor programs. So the work I do with the National Witness Project has provided some examples of that. We have lots of examples at kind of the policy level for increasing access for low-income and uninsured women through the Breast and Cervical Cancer Early Detection Program. And then people like Maria Fernandez, Matt Kruder have done some innovative work thinking about implementation in kind of innovative community settings for cancer screening. So everything from, community-based organizations like the YWCA to laundromats. So again, some innovative work being done in that space as well. With HIV, we've also, we have a pretty strong evidence base in terms of representing kind of diverse populations and settings. The CDC, again, has that really nice website and resources, and a lot of the HIV prevention interventions have been developed for specific racial and ethnic groups or settings, and many are gender specific. And again, I mentioned, Wingood's program, which I'll be talking about. And again, a lot of these programs recognize the structural inequities and social determinants of health that underlie these health inequities. And so that's often built in as important parts of the program. So again, adaptation is really thinking about what is the extent to which the program needs to be adapted to reflect the new population or setting in which we're implementing it. So just from an implementation science perspective, we have had, again, just like our conceptual frameworks, we've had a lot of adaptation frameworks introduced. So there are actually 13 frameworks that have been introduced, and these, again, are more process-oriented frameworks for guiding adaptations. And often this has been cultural adaptations, as I talked about, and in some cases this also reflects setting adaptations. So for example, maybe moving a colon cancer screening program or decision aid from a hospital setting or academic setting to a federally qualified health clinic setting. So that might be an example. Maria Fernandez and Com Scoffrey have done a nice scoping review. I believe this came out in 2008 in Translational Behavioral Medicine, and this really provides kind of an assessment of which frameworks have been put forth, and then also goes through what some of the key components of those frameworks are, which I'll highlight. And I'll be going into more detail on one of the frameworks, the adaptive framework, which I find particularly useful. Again, as we've talked about, adaptation is really about this balance between fit, so making sure the program is compatible with your community and stakeholder needs and goals, while you're still trying to maintain some level of fidelity and really make sure that the intervention itself, the essence of it, the theory underlining it, and the core components are still reflected. So again, it is not a perfect science, but I think these adaptation models can help you achieve some balance with respect to fit and fidelity. Some people have talked about this notion of fidelity consistent modifications. So again, these are the ones that try and preserve the core components, and fidelity inconsistent. So these are the ones that might be those reactive kinds of modifications that actually alter the core components of the intervention. So those are the ones that we want to try and avoid. And again, some of the ones that you might think about are, as I mentioned, if you're choosing an evidence-based intervention, let's say you chose an intervention for cancer screening and you want to implement it for a completely different topic. So maybe it's for cancer screening. That's an example where it might be a fidelity inconsistent modification. It's for a completely different health topic. So that's one that, some people talk about these as kind of green light or red light adaptation. So that might be a red light adaptation. Some of the general processes that underline these adaptation frameworks are this concept of, again, as with is often foundational in implementation science, knowing the population, the context and setting. Again, thinking about, just like we went through earlier, identifying the existing evidence-based interventions with high potential for fit with the population, setting and resources, trying to understand what those core components are that you're going to keep in place, identify some of the mismatches between the program you've selected and the new context or population, think about and understand potential barriers to implementation as well as potential solutions, and then really document the adaptations that you've made so that if you're making them, you can understand the impact they might have on some of your outcomes. And again, this is often not just a one-time approach. There might be kind of an iterative feedback and refinement process. So again, assess fit, assess acceptability, involve the team, stakeholders, adapt it, and then again, pretest, pilot test, and revise. So really, again, this is a bit of a more iterative process. So one of the most successful and wonderful, I think, planning models has been adapted. So this was created by Ralph DiClemente and Gina Wingood. It was originally developed really in the context of HIV interventions, but really it's now really broadly used across a range of types of topics. And again, it really emphasizes acceptability, do the key stakeholders like it, Is it feasible? Can it be implemented successfully? And efficacy. Does it do what it was intended to do? So again, it gets at those issues of fit and fidelity. So these are some of the key stages in the adapted model. So again, this is specific to HIV, this example, but you can think about this more broadly. So again, on doing a bit of a needs assessment, assessing the issues around the HIV, behavioral, or whatever the health issues you're studying and whatever disparities you're trying to understand, deciding on whether you're going to adopt an existing intervention or adapt it. And then again, really trying to think about understanding from a range of experts and stakeholders what needs to be adapted. So what I think is so cool about this adapted model is that they use this innovative theater test process. So they actually bring in stakeholders and topic experts, so actually people who would be receiving the intervention and delivering it, and really kind of go through kind of step by step the intervention. So, if it's a behavioral intervention, they might be doing role playing, or they might just kind of be talking through it, seeing the materials. So it really gives a hands-on opportunity for people to provide feedback and input. And again, integrating that feedback, making sure that the science is still reflected in it, those core components are still there, really thinking about then piloting it again and getting feedback on it, and then piloting it before actually implementing it. So I think that theater test piece is really innovative and a great way to involve and engage stakeholders, the range of stakeholders that you want to involve and that you have identified. Here's one example. So I highly recommend Gina's article from 2008 on the adapted model. It provides such great information. So she goes through one of her interventions, which is this gender empower empowerment intervention for African American youth. And she thinks about identifying for the reader what the core components are, and then thinking about if we were to implement this and have it adopted in, she did a lot of work in mega churches, non-denominational mega churches in Atlanta. What would that need to look like? So she goes through all her methods, how she involved the stakeholders, who she involved, who were the key decision makers within that context, who did she involve as topical experts, as stakeholders in terms of the behavior, in terms of the theater test. So she leads you step by step through that whole process. And then she gives amazing examples of what some modified language or messaging or strategies might look like. So, that she learned through her work that it was important to address the concept of destiny, which was valued by the church, to address the concept of self-righteousness, and to really get at some of the specific concerns about how they were going to frame some of the HIV prevention messaging. So I love her specific examples. And again, she lists the core components at the bottom, which were kept in place while these other elements were adapted. She has another great example of how she thought about this, a similar HIV prevention intervention that she'd tested and had adapted it to Zulu-speaking female adolescents. So again, she goes through the whole process of leading you through those steps, and then specific examples, keeping the core components in place. How did she modify the value clarification activity, for example, to be more reflective of the holistic perspective that she learned was important from the stakeholders? How did she modify the activity on strong African American women to enhance ethnic pride in South African female teens? So again, great examples of really planned, proactive, stakeholder engaged modifications. So I think this article is excellent. Another adaptation, adaptation model is MAP, or the map of adaptation process. Again, it goes through a lot of these same steps of, assess, select, prepare, pilot, and implement. It's a little bit more detailed, particularly in terms of if you're working in a more large or maybe more top-heavy organization in terms of getting leadership involved, what that might look like. I think the adaptation one is particularly helpful for a community setting. So this is just another example. If you just want another example of a hands-on specific model that could help lead you through this process. And again, here's the citation here from McElroy in 2006. I just want to go back a bit to health equity in particular. So I think these models are useful for having us think about adaptation. And I think, again, often at the heart of our adaptations in community settings is health equity and is this goal of addressing health disparities. But I think it's important to note that I think health equity has often been implicit in our implementation science and D&I models and frameworks and not explicit. And I think some factors have been missing. Issues around medical mistrust, power, experiences of discrimination, community level. A lot of these have not been explicit. Eva Woodward and colleagues, just this year in 2019, they published the Health Equity Implementation Framework using the specific example of hepatitis C. I think it's a nice start, moving in the right direction. But again, I think there's a lot more work that we can do here. I know we've seen REAIM, the evaluation framework that I've mentioned, applied to think about explicitly how we could track and understand inequities. But again, I think a lot of this work is really in its infancy, and I think there's a lot of opportunities to advance it. Again, I think the more we can make health equity explicit in our frameworks and the way we're thinking about evaluation, I think the better. And again, I think it's often been implicit, not explicit. I think it's increasingly recognized that there's already been a lot of work done in social determinants of health, in community-based participatory research. So often in implementation science, we don't need to, recreate this whole area of work, but more thinking about how can we learn from and bring in work that's already been done on health equity. I think that for implementation science researchers, there's a lot of education that needs to happen in terms of, what does health equity mean? How do we move beyond just thinking about racial and ethnic disparities? How do we think about, moving more towards kind of resilience and assets-based approach in our implementation strategies and in our work? So I think that's an important opportunity. And then I think in implementation science, it's also important to make sure in our own research as we're selecting and working with community partners and settings that we're not reinforcing health inequities through the settings that we work with and the populations, and that there are so many opportunities for really demonstrating humility and meaningful engagement, and that we're really living up to this standard in our own implementation science work.